we have debated about for a long time. We are not as honest in answering that as we should be actually. So that's something that we need to really challenge ourselves. All over the world, we are talking about healthcare delivery through primary healthcare system or primary healthcare providers and so on. And I still believe that's a good way to go forward. But I think we need to qualify that statement, because even in developed countries, mental health care delivery in the hands of general practitioners or family doctors or primary care providers has not succeeded as much as one would have believed it should have. And there are many, many reasons for that. One reason is what we heard this morning and this afternoon very clearly, that ASHAs are overworked, primary care doctors have too many things to do, the ANMs have a target on deliveries, and can you really pile on mental health care on them, and to what extent? What can you expect out of that? And more important, the question that was asked just 1 hour back, what impact will it have on their targets and their effectivity on the priority healthcare programs like MCH, like HIV, like malaria? And by including mental health, you are gaining something, but maybe you are losing more on the overall health front. And that we have to really honestly answer. I am not posing that question in front of policymakers right now. I should, but that's a difficult question to answer. But the second question is, as you asked, what are the alternatives? And I think we need to really think very hard about that. I do not have the answer, but I have a few experiences to share. The kind of experience that Sri Lanka has had. Sri Lanka in the last 6 to 8 years has experimented with this concept of medical officers' mental health. They call it MOMH. Sri Lanka had about a few years back 35 psychiatrists. There are now about 45 or so, which are obviously totally insufficient for providing care. They started training medical officers for 6 months in mental health care, and those medical officers were posted in the regions, and they have had very good success. The admission rate to their mental hospital has decreased considerably because care is being provided at the community level. The people have been receiving care in general hospital setting. There is an 8-bed unit in all the provinces which admits people for short time, looks after discharges. So that's one model. This is not a primary care doctor being trained for mental health and looking after all other things along with mental health. This is different. These are people who have been trained in mental health, and they spend more than 75% of their time on mental health. So they are not medical officers, they are medical officers mental health. So they are in a way specialists. But what they do is to provide secondary care. The primary health care people provide the basic care, and then they provide the backup and support to that. There is other model of say Belize, which is a very small country, but Belize has this experience of having mental health trained nurses, community mental health nurses, who are the frontline workers, and they do only mental health, they don't do anything else. And there are many other experiences. The lesson from that seems to be, there has to be a person within the healthcare hierarchy, within the healthcare system, who gets up every day in the morning and thinks about mental health, which you do not expect a primary healthcare doctor, general doctor, or a general nurse to do, because he's also thinking about maternal health, HIV and deliveries and vaccinations and malaria and tuberculosis. So the first thing which he does in the morning is not to think about mental health. He thinks about it only when somebody reminds him. There has to be a person in the system whose job is to think of mental health and to do that oneself, but also to make other people think of that. And that person can be nurse, can be doctor, but more or less exclusively on mental health. And that's what I call the secondary care backup to the primary care. I am not saying that the general primary care doctors and nurses should not do mental health, but what I am saying is there has to be a person who's guiding them, supervising them, supporting them, and carrying on the load of looking after some of the things that are not done or will not be done by those people. That's a dedicated mental health person. Not a psychiatrist, but somebody. In some cases it can be a psychiatrist, of course, but in some cases. So I think what we've done is to focus too much on primary care and less on secondary care. And that's the person that we need really. And that's the message which is coming out very clearly from many of the projects that were run. So I think that's an alternative we should think about. In Sri Lanka, they also had another position, which is called the community support worker, who are not medically trained. They are a graduate from a college, but not in psychology, any graduate. And they are given a training, and their task is twofold. One, to go in the community and supervise the community health workers on mental health aspects. And second is to see to it that people with mental illnesses not only come for treatment, but they followed up in future. And that's a dedicated person, looking after basically mental health and psychosocial areas. There are 500 of them in Sri Lanka, and they're doing wonderful work on a very small scale. So those are the kind of perhaps alternatives that should be tried out. Whatever you call them, there has to be a person whose task is mental health. And if you can find that person, and more importantly, keep that person in the system for long enough, because sustainability is a big problem. What happens to that person after 5 years? Is she doing the same job, or is there some career path that you can build up? That could be one alternative. But this is very open area, so I'll be very happy to learn from the experience.